So let's go over the steps for RSI and fasting guidelines. I think it's important to have a solid set of steps to go through when you're doing an RSI because it's a very specific procedure. So you'll start with step 1, prepping your equipment. And now this is not an exhaustive list of all the things you'll need to have ready. So, but specifically, have your suction on at the head of the bed. You need this to be immediately available in case of regurgitation so that you can suck stuff out of the airway if necessary. You should have this ready for any case, but the key difference here is that it's actually on and you could grab this in like 1 second if you needed to. Having your tube ready with a syringe to inflate the cuff, so don't bother with that handheld manometer. You just want someone to be able to inflate that cuff immediately after you have the tube in place, because your airway is not secure until that cuff is up. So even if you intubate someone, that's fine, but they're still at risk of aspiration until the cuff is inflated. So having that syringe ready is very important. You want to set yourself up for success on your first look and passage of the tube. So whatever other equipment you need to ensure that, you're going to be extra careful that you have first trial success here. So if you think you'll need a stylet your tube. If you think that you might need a glide scope, just get your glide scope rather than trying to see what you can see with direct laryngoscopy first, because this can be a large addition to the amount of time that it takes. And then prep your drugs, again, with fixed dosing. So however much propofol milligrams per kilogram you think is appropriate, draw that up so that you can give that all at once. Positioning of the patient, make sure you do this while they're awake. So you don't have to try to reposition them for better intubating conditions while they're sleeping, because that would take extra time. And again, if there's C-spine injury, then you would need to consider protection of the C-spine when you're positioning the patient. We pre-oxygenate, which is very important because we are not going to bag mask ventilate the patient. So all of their oxygen has to be on board before they stop breathing. We're going to pre-treat with fentanyl. We use cricoid pressure, which is a special step for an RSI. And the idea behind this is that you would, so here's your cricoid cartilage. And so you would press down on the front of the neck, and that should ideally squish the esophagus, which is sitting below. And that would occlude the esophagus so that no gastric contents could be regurgitated. Now, this doesn't always work 100%. The esophagus could be off to the side, so it might not be totally effective. And then the other issue is that it can distort your airway anatomy a little bit, especially if someone pushes too hard. Regardless, this is still part of the official RSI steps. And just remember that this is not burp. This is different than the back upright pressure that you'd apply to the thyroid cartilage to optimize your view with direct laryngoscopy. This is the cricoid pressure is applied to the cricoid cartilage, which is obviously below your thyroid cartilage on the neck. Your assistant will be applying this pressure in order to occlude the esophagus. So it is not to improve your view. This is to squish the esophagus. This is also called the Selleck maneuver. So not burp, but the cricoid pressure is called the Selleck maneuver. All right. Next step will be, and you hold this. You hold the cricoid pressure until our step that says release. So next is induction and paralysis, and this is combined again. So it's your probe directly followed by your sucks. Then you're ready to intubate as soon as you have your fasciculations. So you'll intubate, get the cuff up. That's very important. Again, your airway is not protected until the cuff is up, and then confirmation of your end-tidal CO2. And only after you have your cuff up and confirmed placement in the trachea can you release your cricoid pressure. So last step of this will be releasing the cricoid pressure. So I've just kind of starred the steps or things here that are especially important and differentiate the RSI from a normal induction. So suction, having the syringe for the tube ready, making sure you have your first attempt equipment ready to go. Pre-oxygenation, you do that normally, but it's extra important for your RSI, and your cricoid pressure is a unique step to this. Of course, following prop directly by succinylcholine is, again, exclusive to the RSI, because usually you would check for the response to propofol. Okay, so fasting guidelines, this is what you need to say that someone is not at risk of aspiration or not full stomach. So clear liquids, you need at least 2 hours after. People will often be instructed to drink juice before surgeries, but it has to be a clear juice, so apple or cranberry juice. If someone misunderstands these instructions and drinks orange juice, that is not a clear fluid, and that actually does happen for people coming for elective cases more than it should. As well, having milk in the coffee is not a clear fluid anymore, and so that puts you more in the 4 to 6 hour range for needing to be fasted after that. Breast milk is 4 hours, infant formula 6 hours, non-human milk 6 hours, light meal. So this is non-fatty foods. This would be something like maybe if you have like tea and toast, or maybe a small muffin. That's okay for a light meal, but still be careful about that. And then you should have 8 hours after any decent sized meal. There are things that you should also consider, like delayed gastric emptying, where you should be careful about the fact that someone might still have a full stomach even 8 hours following a meal. So if you have a trauma, gastroparesis from diabetes, there are a lot of things that can cause delayed gastric emptying. So consider that as well when considering the possibility of full stomach. I've also written down here, technically you can do a modified RSI where you stray from the regular steps of an RSI. So if you do anything different than what is classically described, you are then by definition doing a modified RSI. So maybe you'll use ROC instead of SUCS. And remember, our typical intubating dose for ROC is 0.6 milligrams per kilogram, which kind of has like a slow 2-minute effect. But if you give higher dose, so 0.9 to 1.2 would be ideal, you have a much faster onset. So you can get onset of paralysis within about a minute after 1.2 milligrams per kilogram, which is very close to what you can get with succinylcholine. So you can consider that for an RSI if there are contraindications to giving SUCS. Some people will do RSIs without cricoid pressure, and then that's a modified RSI. So I'll leave these here. Make sure you know the RSI steps, know what differentiates an RSI from a normal intubation, and then how that would differ from a titrated induction, and what your fasting guidelines pre-op should be so that you can include that in every pre-op history that you do.